Today, the Committee on Health, Tourism, Historic Preservation, Land and Justice is now called to order. Today is Thursday, October 1st, 2020. The time is 2:03 p.m. Notices for this oversight hearing were disseminated via email to all senators and all main media broadcasting outlets on Thursday, September 24th, and again on Tuesday, September 29th, 2020. The notice was also published in the Guam Daily Post on Thursday, September 24th and September 29th. This Zoom meeting is hosted by the Guam Legislature's MIS staff and committee staff. The host of this hearing will mute all Zoom participants until called upon by the chair. Questions and testimony shall be confined to the substance or nature of the agenda. The personal inference as to the character or motive of any senator, any individual testifying is not permitted. Any violations of this general rule of conduct will result in removal from the public hearing by the host. Each member will be allowed to pose a question to an individual testifying for a round, and we will be provided another round as needed. And of course, we will try to adhere to time constraints. I want to thank my colleagues for being in attendance today and thank them. Legislative Secretary Amanda Shelton, Senator Amanda Shelton, Minority Leader Senator Terlaje, Senator Jose Pito Terlaje, Senator Luis Muña, Senator James Moylan. Thank you again for being here today. I'd also like to thank, of course, the Director of the Department of Public Health and Social Services and the Deputy Directors, the two Deputy Directors who are in attendance today, and all of the staff who have been sworn in prior to us going live on air. And thank you all for being here and for your participation today. So our agenda item for today is an oversight hearing to follow up with the Department of Public Health and Social Services on the status of the COVID-19 case investigations, contact tracing, and public health authority powers under Chapter 19, Title 10, Guam Code Annotated. This is the third legislative oversight hearing held by this committee to receive updates on the status of case investigations and contact tracing. Today's oversight hearing will focus on COVID-19 contact tracing and investigations capacity, implementation and results of the tracing apps, public disclosure protocol for case investigations, and contact tracing information, status of the CARES Act funding requests and other federal funding for case investigations and contact tracing, and public health authority powers under Chapter 19, Title 10, Guam Code Annotated. At the September 10th oversight hearing, we were informed by the Department of Public Health of the status of the workforce capacity for contact tracing and investigations, the status of federal funding, containment and technology, the Department of Defense contact tracing data, and the public disclosure of information. So today's, hopefully we'll get updates on these areas. And now I'd like to recognize the director and ask him if he would like to introduce his team. After that, I will ask questions, and they have been given these questions in advance, but then they will make brief presentations in regards to each question. So Director Art San Augustine. I can't hear you, Director. You might be muted. Still can't hear you, Director.
Good afternoon, Chairperson Terlaje. Okay. Our Legislative Secretary Shelton, Amanda Shelton, our Minority Leader Senator Terlaje, and Senators Moylan, Senators Pito Terlaje, and I believe there's Senator Luis Muña. Good afternoon. This afternoon, we have another oversight hearing, and we'd like to present to you our work in progress, where we are, what we've done, and what the future. Senator Sabina Therese as well. Good afternoon to you, ma'am. Sorry about that. This afternoon, we'd like to present based on the 15 questions that the oversight chair has prepared for us to respond to. Last time, we were able to present all the information. We'd like to use the same format. We're also receptive, Senator, our chair, to the request that we would also have someone go over the sit rep, what we call the situation report. That was requested, and we have no problem with that. So my team this afternoon, there's quite a bit of us. We have our 2 deputy directors, some division heads taking on different roles in the response to COVID-19. So with that, I'd like to go ahead and ask if you would have each one of them just introduce themselves. And I'd like to also make reference to your role, your function, your position in the response to COVID-19 for our senators this afternoon to have a sense about what role and what part you play in the response. Thank you.
Great. Thank you, Director.
So, half a day and good afternoon. I'm Terlaje. I'm the Deputy Director for the Guam Department of Public Health and Social Services. And I'm delighted to be here today. I know this is a very fast-moving time for us as we address the pandemic here on Guam, and actually globally as well. And my role actually is multifunction. A lot of the issues I'm currently working on actually has to do with like decompressing the hospital to make beds available for COVID patients that are coming in, addressing other issues. I think both deputy directors we are sort of an extension of ART, and that we're addressing quite a number of meetings that are actually addressing the pandemic as well as the normal daily functions of public health. So thank you. I'm delighted to be here today, and hopefully we have the answers that you guys are looking for.
Pardon me. Thank you, Deputy Director. If I could just also introduce at this time my Vice Chair, Senator Sabina Perez. Thank you for joining us. Sorry for the interruption. Please proceed.
Lori?
Thank you very much for having our team here for this oversight. I appreciate it. I'm Lauren Duenas, Deputy Director for Public Health, and I believe the other Deputy Director really told our role and dealing with the pandemic and also trying to keep the operations going on because we still have the grants and all the other things that we've got to do. Thank you.
Hi, my name is Suzanne Kanishura, the Chief Public Health Officer. I'm actually the Medical Operations Lead, so I oversee the outreaches, isolation, quarantine, surveillance, epi, you name it. I'm actually in charge of all those.
Hi, good afternoon, half a day. My name is Tom Nadeau. I'm the Chief Environmental Public Health Officer with the Division of Environmental Health. Our division is known for conducting sanitation inspections of health regular establishments. For COVID response, now we're also including to conducting enforcement of the COVID mitigation measures required by the executive order and our memos, mandates that we issue. Thank you.
Good afternoon, Senator and the Committee on Health. My name is Grace Garces-Verdalio. I'm the COVID Response Incident Public Information Officer. I'm responsible for messages that go out to the public and for our education community health outreach. Together with Vivian Pareja, we do messages for the public and the media. Thank you.
Hafa Chairwoman Terlaje, and to the Guam Legislature. My name is Janella Carrera. I'm the Public Information Officer for the Department of Public Health and Social Services. My role with public health is to provide information to the public, field media requests from members of the media. I'm also responsible for fielding requests for Freedom of Information Act from the public. I'm also a member of the Joint Information Center on behalf of public health, and any requests for information from the public, we draft press releases, we oversee social media accounts, the website, we participate in drafting of policy and any type of information that gets disseminated to the public. Thank you.
Hafa Madam Chair and Honorable Senators, my name is Annette Uggan. My regular role is the administrator for the Bureau of Communicable Disease Control. For the COVID response, I oversee the epi surveillance branch where the contact tracers, case investigation, the lab, as well as the surveillance unit are located. Thank you.
Hello, I'm Ann Pavutsky. Good afternoon. I'm the territorial epidemiologist for the island of Guam. My role is to look at the data on all diseases that may affect the people of the territory of Guam, including COVID-19 and chronic diseases.
Hi, my name is Anne-Marie, the Laboratory Administrator for Public Health Lab. I oversee the laboratory, its operations, and ensure that we're all performing our upon CLIA regulations and other regulations, and ensure the staff has proper proficiency testing and competency assessments. And I was also taking on the position of lab administrator in 2015. I also am acting biosafety officer. And so we've also been coordinating all the rapid testings, distribution of rapid tests. ID Now was the first, and I think coming soon would be the Binax Now rapid test, and other antigen testings that are on its way. So the lab staff consists of 5, and our lab director is a part-time status, but we're hoping in the future to have a full-time lab director. And it'll be our goal to increase capacity, maintain what we're doing, and improve it. Continuing performance improvement, we also track. And CLIA inspection is scheduled for January 2021. So we're preparing for that. And just having routine audits among ourselves. It's been quite busy and challenging, but we're managing to do with the resources we have. Thank you.
Afade, my name is Tommy Taidugui. I'm the Administrative Services Officer within the Division of General Administration. I am the Chief of the Admin and Finance section within our Public Health Incident Command, and I provide the administrative support together with the financial support in assisting the other sections of the Incident Command.
Good afternoon. My name is Chima Mbakwem. I am the TB Enhancing Disease Program Manager for the COVID-19 response, the Containment and Infection Control Lead.
So, Chairwoman Terlaje, I believe this is all the team members from the Department of Public Health and Social Services that serve on my team this afternoon for the oversight. We do have your questions as you have presented them, so thank you for those questions. Would you like us to proceed in responding to them, Chairwoman?
Sure. If it's okay, I'd like to. Well, go ahead. Yeah, I was going to read the question so that everybody could follow along as to what our goal is. But go ahead. We'll see how this goes.
Well, what we can do, Senator, I'm so sorry. What we can do, Chairwoman, is Deputy Director Uggan could read the question, and then the staff could respond, and we can just go along that way. If that's agreeable with you, Senator, Chairwoman.
Yes.
All right. Thank you very much, Deputy Uggan.
All right, no problem. In August of 2020, a diagram was provided to the committee that visually describes the Department of Public Health and Social Services process for reporting positive COVID-19 cases and case investigations. Is the process in this diagram up to date? And can you provide average times or timelines for each step in the process? See attachment at the end of this letter.
And so we can have Annette and Chima. We'll start with Annette.
Thank you, sir. No, Madam Chair, the process that we provided you earlier on has been revised and updated. Over the past week and a half to 2 weeks, our Containment Infection Control branch, along with my branch, have worked to improve the timeliness of notifying individuals, especially for the mitigation efforts, to have these people know their status and to isolate at home, and to help us obtain at least a household contacts who are at highest risk of exposure, and so that they also can be informed and be quarantined until the case investigator and contact tracer can turn around and do the full interview, which can take about an hour. And so with this new process, ma'am, we will share with you the update. And so it's to streamline and to ensure the surveillance unit with the lab, once they get a positive result, they provide that to the case investigator contact tracing team, as well as the isolation quarantine team, so that they receive it in a quicker turnaround time. Our goal now is to try and have these people notified within 5 to 8 hours. The challenge are the ones who are, again, late night when they're being identified and tested as positive. And so those adjustments have been made. The flow chart has been updated so that we can improve the timeliness of notifying newly confirmed cases as well as their household contacts.
All right, Annette, then do you mind just telling us very briefly, first 4 days, what happens?
So within the, the thing that's changed too over the course of our outbreak is we have more private providers who are helping with the testing. And so that has added to the data flow situation. And so our surveillance unit has worked with them so that they can report it via fax, scan it, and email it to the identified surveillance unit member, or there are those who have the electronic lab reporting like through DLS. And so we're funneling that all into our surveillance unit and lab, who then scan that and send it securely to the isolation team as well as my team. And so that we ensure, one, did the provider notify the individual? The ones who ordered the test need to notify the case of their results. If they are not notified, then we have our public health doctor who will call. And again, it's all, we're trying to get it within the 30 minutes to an hour that we have this positive result received by public health. We want to make sure this person is notified of their results. Once they're notified, our isolation team steps in to confirm it, to advise them of the situation, and they initiate this home assessment to see is the home able to, are the individuals in the home able to properly and safely separate from each other to reduce ongoing exposure. They initiate and get the household contact members, so they get an idea how many are contacts and may need to be, and also need to be quarantined and tested. And then from there, that initial information is provided to my team. And this change has helped also reduce the number of calls that different public health teams have to engage with this new case and their family members, because we were receiving some concerns, too many calls from public health and different public health teams. And so we're trying to, this change has helped streamline that. And so they're already notified, they're have the initial information about how to separate. Based on the assessment, the isolation team can then look into whether this positive case needs to be relocated to our isolation facility, or whether they can properly isolate at home. And then we get the information that they gather and add it to our case investigation and contact tracing file. And then we will initiate the phone interviews to do the 4 to 5 page interview in depth, as well as for our contacts. We also interview them, and then we schedule them for testing at our dedicated public health drive-through clinic. And then from there, the isolation team takes over and the quarantine team takes over for the active monitoring of these individuals.
Okay, so what's the time period at that point?
Notification with isolation is within hours. Our case investigation contact tracing on my side is a 1 to 2 days turnaround time.
All right, but by the time you decide whether they're going to get to isolation or not, that's you're saying you first make a call within 30 minutes of a positive result. So yeah, how much time for a person to get to isolation? A day? Within a day?
CHIMA's team coordinates if they need to be moved to the ISOFAC, ma'am. And so they work that out and trying to get them moved in as quickly as possible.
And then when is you're saying you complete your, I'm sorry, what you said you, sorry, let me turn this phone off. My apologies. So, okay, so you call within 30 minutes of a positive exam between 5 to 8 hours of the individual being notified. If you notify them, if the providers haven't notified them, public health will notify them. And then all those reports are sent simultaneously to the isolation team and the surveillance teams, the investigation teams. And a person should be interviewed about whether he needs isolation in a different facility. So would you estimate that at least that initial discussion takes place within 1 day?
No, ma'am, that's a, Chima's raising hands, but they're trying to go for within 5 to 8 hours of us receiving the positive case result that our team, and so Chima can add, sorry. Go ahead, Chima.
That's what it sounded like. Within, yeah. It's great, 5 to 8 hours is much better, so. Chima? I can't hear you, Chima.
Ma'am, I was trying to add on to what Ms. Annette just explained to you. The whole strategy for mitigation of COVID-19 on the island is using quarantine and isolation as our first strategy. So what we've worked out is in the first few months that we had COVID, the lab reports were only coming through public health and DLS. And we had a seamless system of identifying the positive cases and notifying them and isolating the positive cases and making sure that we quarantine the family members. But when we increased to having the multiple test sites, we are working with them to see if we can have a quick turnaround of between 1 hour for notification and 5 to 8 hours for isolating and quarantining the family members. This will basically give the contact investigating team, this is the real case investigators, time to reach out to the index and elicit more information for them to continue community contact tracing. The strategy here is at the point of notifying the index case, the interview will extend to the family members where close contacts of this individual are identified at that time, and the same call is made to completely quarantine them. The reason for this strategy is if you're using the concentric circle for contact tracing, the high-risk group is the close family members who are the closest contacts. So what public health is doing is to make sure that the individual is correctly isolated to stop the spread of infection, and then also quarantine the family members and monitor them for symptoms, and then send them for testing if they have symptoms within the 14 days that they will be in quarantine. That gives us enough time to elicit more information from the index and do more community contact tracing. So this strategy does not have the same timeline like we had at the beginning when we had to go through the surveillance team before we came to the quarantine and isolation team. So it's a time-saving mechanism, and also the fastest way to stop the spread of the virus on the island. And further down the line, we'll talk more about the kind of technologies that we have in place now to ensure that information is handled better. Thank you.
Okay, great, thank you. Annette, please continue.
We will be sure to provide you the updated workflow that Tim and I have discussed that again crosses over the different branches and within our respective units. So you can go on to the next question, Senator, if you would like, unless there's questions.
Yeah, I intend to pass that workflow out to the senators. So if you could add just your goal time, your time goals for each of those steps. Just that would help. Thank you. All right, please proceed. Okay, I can't hear anyone if anyone's talking. Director?
Are we on
Yeah,
mute?
no.
We're off. Can you hear us now?
Yes.
All right, I'll start again. Question number 2. During the September 10th oversight hearing, the department reported having 20 investigators and 24 contact tracers to address the latest surge in positive cases and was in the process of getting 14 more tracers and investigators through an epidemiology and laboratory capacity grant. How many investigators and contact tracers does the department have on staff to date, and how many are still in the process of being hired? What funding source is being used for the current investigators and contact tracers? What funding source will be used for additional investigators and contact tracers that will be hired? Which outside agencies are currently conducting their own investigations and contact tracing, and how many investigators and contact tracers are utilized within those respective agencies?
And so Terry, calling
Thank you, sir.
Thank you.
So in regards to the number of case investigators, we now have 22, and we had recent hires over the past couple of weeks. September 14th, this individual who was actually volunteering for us is now on board under the ELC grant as a CDC coordinator 1. Then on September 28th, we had 2 individuals start with us. One is a CDC investigator through our ELC grant, and then we have a contact tracer through the CDC Foundation. So now for our number of contact tracers, we have increased by 25 in my unit. And then under Chima's branch, the isolation quarantine sections, he's had 3 of his staff trained up. And this is to help them understand the contact tracing component, since we've updated and adjusted our workflow that we discussed earlier, ma'am. In regards to funding source, we do have, again, through the CDC core grants, immunization, STD HIV programs, the TB program, as well as the epi and lab capacity programs, where these staff that are funded through these core-based grants are assisting with the COVID response under the case investigation and contact tracing teams. We also have been fortunate to have the CDC Foundation that are providing us personnel, and they are aligning their roles to match the government of Guam positions like CDC investigator, as well as CDC coordinators, since the title of contact tracer does not exist in the government of Guam. And then funding for additional staff will come from our EOC COVID-19 grants that we have, specifically the CARES Act, which is $500,000. And of that $500,000, about 42% is for personnel. And we have 2 people under that that we've just onboarded. And then we have under the enhanced detection grant, the one that is $5.6 million, of which $2.3 million is personnel. And we have an additional 12 bodies that will assist for contact tracing and case investigation. Through the CDC Foundation, we hope to hire 2 more individuals. One would act as a contact tracer. The other one is a response coordinator, which is equivalent to a CDC coordinator 3, which is like a supervisor. And so these individuals, we are in the process of already profiling under the government of Guam positions for the LTA, selecting individuals and processing in-house GG1s. For the CDC Foundation, we actually interviewed someone yesterday and we selected that person for the contact tracing. And so we were just waiting for CDC Foundation to process and get this person on board. And then we do have the response coordinator position that we are coordinating, scheduling the interview, hopefully sometime by next week, ma'am. In regards to the other agencies, GMH was the first agency that assisted with contact tracing. We have Port Authority of Guam, GPA, as well as DOE. These agencies do not conduct case investigation. That is solely handled by our department. In regards to contact tracing, for GMH, we have 8 to 10 staff, and that's part of the infection control unit, the nurses and social workers who conduct the contact tracing, specifically for their personnel who unfortunately became positive with COVID. For GPA and Port Authority of Guam, they each have 3 designated staff within their agencies who have taken the online course. They coordinate and communicate with my team in regards to completing the contact investigation and to schedule them for testing. We do also have plans to work with UOG. We have a pilot test that we will hope to launch by October 19th. They have identified 8 individuals. We have from University of Guam, we have from DOE. We also have from Serve Guam Commission and the Catholic schools who took the UOG UC San Francisco course. And they will be our first group for the pilot test, where UOG will have a contact tracing team at their facility. Thanks to Mr. Carlos Taitano and the School of Health, they're helping us coordinate. They've designated a space at the Global Learning and Engagement Center. They will provide the computers as well as the phone lines so that the team can physically be located there. We have already set up a shared drive, and so that we can confidentially share this information. And so that is set to launch hopefully by October 19th.
Dr. K?
Dr. K, anything you'd like to add? I'm sorry, I can't hear you.
Sorry. So we also have 38 of our staff take the contact tracing training. So there's also 38 people that can actually assist in the existing contact tracers in their investigations. So when they're needed.
And I'm sorry, I failed to mention GDOE. Their process is that they actually also help with contact tracing. And so the respective school nurse will coordinate with Julieta, the overall nurse administrator. They provide us the list of individuals identified as close contacts at the work site, the respective schools, and then we will coordinate in scheduling as well. My apologies.
All right, so could you maybe say that again with how many are active full-time in contact tracing and investigation, and how many are, I guess, on call or assistance from the other agencies? Total, yeah.
So for public health, we have 22 case investigators, and the case investigators can do the dual role of investigation and contact tracing. Then we have 25 contact tracers under my branch, and Chima has 3 that have been trained up, so that's 28. Within GMH, they have 8 to 10 staff, and that's like infection control nurses and their social workers who assist to do contact tracing in their agency. Then GPA and Port Authority of Guam each have 3 designated staff who have taken the training, and they coordinate, collaborate with our team again for the investigation, interview, as well as testing. Guam DOE, it's within the respective school nurse counselor, the school nurses, and they communicate that to Julieta, and as the nurse administrator, she provides the list of contacts to us. So approximately 42 nurses at DOE. They provide us the information. And then for UOG, the pilot right now is for 8, ma'am, and that's a mix of, we have 3 UOG staff, 3 GDUO staff, 1 Serve Guam Commission, and then 1 Catholic school staff who took the UOG UC San Francisco, and they will be the first UOG contact tracing team with the launch date anticipated on October 19th.
And then we also have the 38 other staff, nurses, social workers, program coordinators that also took the contact tracing training.
All right.
So they'll be used as needed.
Okay. All right, thank you.
There we go. So moving right along, question number 3. The investigation and contact tracing protocols you provided the committee in August noted that 25 investigators and 50 contact tracers were needed for the higher estimates of cases based on 5 assumptions. Assumption number 1, 1,500 arriving residents per 2 weeks. Assumption number 2, 360 exempt persons per 2 weeks. Number 3, 150 active cases with 3,750 HH and community contacts per case. Number 4, 3 investigators per 15 confirmed cases. And number 5, contact tracers per 75 contacts. Are these estimates and assumptions still accurate? We currently have over 600 active cases based on these assumptions. Doesn't this mean that 100 investigators and 200 contact tracers are needed? How many more investigators and contact tracers does the Department of Public Health and Social Services plan to add to their capacity? Is this ratio consistent with ratios recommended by CDC or by trainers with UCSF?
We have not changed those assumptions, Madam Chair. The ratios used by CDC and UC San Fran are based on US populations of in the millions. The other model they used was for New York City, which again is in the millions. So we have not changed our assumptions that we based ourselves on back in June. In regards to the 600 active cases, those individuals are still under isolation monitoring, and they do not need to have their case investigation and contact tracing. Once our team completes the contact tracing, case investigation, the testing, it now goes over to the containment and infection control branch for these individuals to complete their isolation. And again, it's based on symptoms, 10 days after the symptoms, up to 14 days for the quarantined individuals that have to be monitored. So that's why they're still active. They do not need to be investigated. We've already completed our component of the response, and now it's just a matter of monitoring them until they are released from isolation or from quarantine. In regards to the number of individuals that we plan to hire, as I mentioned earlier, we're looking at 14. There's going to be 12 under the ELC COVID grants and 2 through the CDC Foundation program. Thank you.
Could I ask the reverse, Annette, if with the number that you have now, the 22 and the 25 and some of the backup, but with those numbers, what is the average number of cases that you can handle?
It fluctuates, ma'am. We have normally they try to go for like 15 per investigator. Recently, we've been seeing a lot of our household contacts who are turning positive. And so that makes it a shorter case investigation because they've already been previously interviewed. Their status has just changed from a contact to a case. And so not much work is needed on that part. And so we're also in the process of revamping our structure internally so that we can definitely be more manageable, where we have dedicated data entry people assigned to our case investigator, as well as to have different teams of our case investigator with a contact tracer and a data entry. And so by having the support of Department of Labor onboarding data entry clerks, it's actually alleviating some of the work from our case investigators and contact tracers so that they can get through these phone calls and interviews faster, and they don't need to worry about data entry, which was kind of putting a delay because we also had to input this information into our surveillance system. So right now, our team is normally about 15, but again, as they close out a case that day, they're adding on from the new positives that are being reported to our department.
So 15 per contact tracer, 25 times 15, I've got 330. Does that mean they could handle 330 cases a day?
For their role, yes, ma'am. And again, some of these contacts, unfortunately, with our multi-generational households, large family units, it's one phone call and they do like multiple for the individual households. They literally just, okay, let me pass it to the next family member. And so they can literally finish. We've had one where there was about 10 in one household. And then another individual where she actually had 20 to 30 contacts identified because it's a family compound. And so she just pulled another contact tracer, and they've gone through that listing in a short amount of time, because it was just stay on the phone for over that hour and just keep passing it on to the next family member, or talk to the parent to handle if there are any minors.
Okay, wonderful, thank you. All right, please proceed.
Okay. Did you want to answer that?
Can I answer something?
Sure.
Yes, that's what we're here for.
Okay, so Madam Senator, to support what Annette is saying about the 600 that is in isolation, if you look at our average test daily now, it is between 30 and 40 cases a day. And most of these individuals are in quarantine, in isolation for 10 to 14 days. So if you're looking at the turnaround from the contact investigation team, with the number of investigators they have, they can actually complete and turn around cases in a space of 2 days. And these people the contact investigation is completed between 1 or 2 days. And at the same time, if you look at the number of people we have in active quarantine, these are supposed to be close contacts to these cases that are identified at the point where we initiate isolation for the individual who is the index case. So you're seeing a family of 5 or 10 successfully quarantined and monitored within the same 14 days time period. And if they turn positive, remember they are still in quarantine and they are at home. So they don't become any danger to the community, because already by isolating the index case, we've actually cut off transmission in the community. And then by having the family members who are close contact in quarantine, we've also cut off transmission in the community, because we are monitoring them for symptoms. And if we test any of them and they're positive, we also move them from quarantine to isolation. So as a mitigation strategy, we are using quarantine and isolation at this point to support what the contact tracing team is doing right now. So if you're looking at numbers, the numbers will not actually tell you the actual the numbers will not reflect the actual amount of work that goes into each of the positive cases. So by explaining it this way, you're sure that in a family of 10 where you have one index case, the remaining 9 will be successfully quarantined. And then it also gives the contact investigators time to do a more in-depth elicitation and also move out to community contacts. And right now, with the present lockdown that we have on the island, it's easier for us to do that now. So I think the opportunities that we have by using that contain and isolate strategy now will continue to sustain us until we gradually start opening and then shifting gears. Thank you.
Is it still accurate, Annette, that if we were receiving 1,500 arriving residents per 2 weeks, that was the number one assumption? Well, never mind. You said the assumptions are correct. So does that mean that the 50 contact tracers would be needed for these assumptions if these were the number of cases we were having? 150 active cases a day, 1,500 arriving residents?
Yes, ma'am.
Sorry, I can't hear you again if you're talking.
I'm not sure if you heard my reply, ma'am. It was yes, ma'am.
Yes, I heard you. Thank you. Please proceed, Deputy Director.
Yeah, okay. All right, moving right along. During the September 10th oversight hearing, the department reported that there has been a lag with initiation of trace investigations due to the surge, that contact tracing and investigations begin within 2 to 3 days of a positive case, as opposed to within 24-hour period per CDC's guidelines. What is the current average time that contact tracing and investigations occur for a positive case? Are we conducting the tracing and investigations within 24 hours now?
So as mentioned earlier, ma'am, with our recent revision and change to our internal workflow, our isolation team is contacting these new positives within hours. And so the full case investigation, contact tracing, then occurs 1 to 2 hours time frame, ma'am. 1 to 2 days, I'm sorry, 1 to 2 days.
Thank you.
Okay. So, ma'am, if I can add to what she just said, the containment unit is supporting the case investigators by actually initiating the questions and identifying close contacts, which makes it easier for the contact investigation team to start off the day after or immediately after we successfully isolate and quarantine the index and family members. Because the intent is when the results are, when the individual gets their result, the isolation team conducts an interview. During that initial interview to determine the possibility of the individual being moved to a different isolation place, like moving them to the isolation facility or making sure their home is conducive. Part of the questions that is posed to the individual is how many family members that live in that household. So by that, we identify how many members they have in that household. That would also help us initiate quarantine at the same time. So the time spent in interviewing this contact and index cases is also passed to the investigation team. So the initial investigation starts with the contact with the isolation team.
All right. Thank you, Chima. Annette, if I could just ask one more question on this topic. Is your goal still to hire up to 50? Or are you at your goal now, 25 contact tracers and with the backup, or?
Our goal is still to hire the 12 individuals funded and approved under our EOC COVID grants, as well as the 2 additional from CDC Foundation. However, as my chief had mentioned, we do have other public health staff who have taken the course and that we can pull them up as needed. We also will have the pool that participated and completed the UOG UC San Francisco. But first we want to get through this smaller pilot and then we eventually expand out now. And so again, it won't be specific to public health. It'll be other resources, our partners that will assist us as well.
All right. And is the goal to hire the 14 concrete goal, or is that not concrete?
Oh, we've already had applicants, ma'am. We actually have 2 more individuals who've been selected through the in-house, the LTA position. So it's now getting them through the process of finalizing the GG1 packets and getting them drug testing and waiting for those results and getting them on board. And then we do have approximately 21 individuals who submitted their applications for the various ELC funded positions for the grants that I mentioned. And again, we funded over 30 positions on these supplemental COVID funds that we received through CDC. And we are working on processing them and getting them on board, ma'am. We're working with DOA.
Great, great, thank you.
Okay, moving along. Question number 5. The Department of Public Health and Social Services launched its Guam COVID Alert app through PathCheck on September 10th. It was stated that 60% of the population needs to utilize the new app in order for it to be effective. Can you please provide an update on how many downloads there have been for the app? And what are the plans to increase the utilization and downloads of the app? Grace, Janella, and Chima.
So, Senator, as of yesterday, we had 14,347 users download the app either through Apple App Store or Google Play. That is representative of 19.6% of 73,000 adults who have smartphones 16 years and older. PathCheck, Apple, and Google had a gold standard of 60% of the adult population. So we're not quite there, but we did have partners who did the downloadathon with us last weekend. And we do have plans on printing posters and flyers as we did back in February and March of letting people know that they should wear a face mask, download the Guam COVID Alert, get vaccinated with the seasonal flu or the COVID vaccine when available, stay home if sick, and just listen to our PSAs and our situation report. Janella can talk more about the activities we have planned through the governor's office on a campaign that's set to end next week, and other activities.
Thank you, Grace. So the governor's office is leading an effort to incentivize government employees to download the app. It's a GovGuam challenge, and each agency and department encourages their employees to download the app. And at the end of the challenge, whichever agency has the most downloads or division has the most downloads, they win a prize of, I believe it's $1,000. So that's one way that we're trying to promote the app and get more downloads. There has been some discussions, although nothing's materialized, of possibly doing another download-a-thon. We continue to promote the app through radio interviews, through putting the logo through signature blocks, and also in other press materials, and putting it on social media. So those are ways that we continue to try to get the message across about downloading the app, as well as addressing any concerns about privacy issues. Thank you.
We do push videos, and we were told from the beginning of our planning of launching the app that Google was going to put the Guam COVID Alert app on their search page, their homepage, that Guam users can see whenever they Google, whatever search they're looking for, and that has yet to materialize, so we are following up on that.
All right, please proceed.
Okay, question number 6. Is the Sarah Alert app still being utilized? What is the difference between the two apps? Does the department intend to use both Sarah Alert app and the COVID Alert app simultaneously, and for what purpose?
The Sarah Alert app is actually today. Interestingly, we are launching it today. And it's not, I apologize, it's not an app, unlike the Guam COVID Alert. Guam COVID Alert is an app that you can download off of the Apple Store or Google Play, whereas the Sarah Alert is not an app, it's symptom monitoring, and monitorees are enrolled by a public health official. We do plan on utilizing both simultaneously, and both are digital tools that are being utilized by public health in an effort to contain the spread of COVID-19. So we are launching it today. The press release is actually going to be sent out today, as well as a press kit to explain more about Sarah Alert and how it works. Sarah Alert is when enrollees, monitorees are enrolled into the system, they get a message either through a text, email, or phone call in which they're asked to give information about their symptoms. And these are individuals who are either positive or may have been exposed to COVID-19. And so it's a way for public health to track individuals for symptoms of COVID-19, and it assists us in being able to be better prepared for any developments in COVID-19 and the way in which we track those who are positive or have been exposed to the virus. Guam COVID Alert is more of a way to better prepare or better help our manual contact tracing so that we can learn more about those who've been in proximity to others who are positively diagnosed. And again, one of the main differences is Guam COVID Alert is an app, and you opt into it, and users can go in and download the app into their phone, whereas Sarah Alert it's not an app, and monitorees are enrolled by a public health official.
Are the monitorees enrolled mandatorily after a positive test, or is this again voluntary?
I can answer that, Madam Senator. The Sarah Alert is actually going to take over most of what we're doing manually now. And it is also for long-term use for the island, because after COVID, it also offers a disease-independent approach, so that we can also in future, if there are other outbreaks, we can tailor it to do the symptom monitoring for that large outbreak. So what Sarah Alert does is it enables public health officials to enroll people who are positive and close contacts to positive. Right now, what we do is if someone is positive, when we get the lab result, we call them and enroll them in our system, and we manually call them twice a day to do the symptom monitoring. But with Sera Alert, what we're offering the patient is more of a patient-centered approach where we give the patient the flexibility to report their symptoms at any time of the day. And this can be done through their email address, their email, or it can be through their smartphone, text messaging, or voice call. So what this is going to achieve is that individuals, rather than being manually, individuals can choose what form they want to use to notify public health of their symptoms. And then we have people at the back end who do the daily checks. Right now in my team, I have up to 80 people working for me. So if we start using Sera Alert, what it will do is cut down on manpower, where we can have an individual monitor these positive cases and their close contacts at the same time. And the way it is built, individual positive cases and their households can be monitored at the same time using the same approach that we're using now. So it is a public health tool just to support what we're doing now, going from manual to a technology-based approach to make it more patient-centered for the individuals who are going to be monitored by public health.
All right, and is it mandatory or optional or voluntary?
So, ma'am, the monitoring is part of the public health strategy. So it is the same way we are doing it now. So the individual would have to be monitored by public health if they become sick. Yeah. So
but do they have the option of being called daily by public health or being visited by public health or using this app or using the program or
They have an option.
Yeah. Yes, ma'am. Yeah, like I explained, it's the same app. Is the same approach. There's a voice call, there's a text message, there's an email, but it serves the same purpose that we're doing now, just to make sure that individuals are contacted daily.
All right. Okay. Please proceed.
I know Sarah.
Yeah.
How many employees does this? You said it takes the place of some of your work. Does it mitigate the need for employees, or I expect it's not there yet?
So, ma'am, people have to check in their daily symptoms daily, and if we don't hear from them, then we, the staff, have to follow up on that person. So it does take away from staff resources because they can tell us their symptoms either through text, email, or phone. But if we don't hear from them, that's when we follow up.
Very great. Okay, next question, please.
Okay. Did you want to add anything?
No.
All right. So question number 7, during the September 10th oversight hearing, the department reported it was in the process of streamlining the daily situation report and would be relaxing a weekly surveillance report that provides more detailed information about community spread and positive cases. Have protocols been developed based on a recent Attorney General's opinion that will inform the release of the type of establishments or activities where they have been known COVID clusters? What is the expected timeline to provide detailed information? What new detailed information will be released in a daily or weekly reports? Dr. Ann?
Yes, it's Ann Pabutsky here. The streamlined daily report will happen soon. I don't know exactly when. We've already drafted a template for the weekly surveillance report. It's designed as a weekly surveillance report to look at the epidemiology of COVID, not just a list of establishments and contacts. The type of information, it's work in progress. The types of information, we want to use some examples from other states. We've looked at other states' weekly reports, and we want to also include detailed information on the types of symptoms of positive and or negative cases, the chronic diseases and underlying conditions of both cases and deaths, the types of contacts over time, whether it's travel, household, workplace, community, And we hope to include some cluster analysis that includes types of establishments as well as other information. We don't have an exact timeline because right now we are migrating all the COVID-19 case data into our NBS system, which is the National Notifiable Disease Surveillance System that we use and other states use. But this is used for all communicable diseases. We're trying to migrate all of our data in there. It's going to take another 2 weeks, and then we'll be able to have a little more better data management, so we will have the more accurate and updated information, and that is a work in progress. As for the protocol, I believe we agreed that we would list the types of establishments and or activities, but I don't know if we decided on naming establishments. I'll punt that to Annette.
No, we had discussed that, you know, the only time we would name is if the establishment was uncooperative. And prior we were mentioning, or if we would not be able to contact these individuals like patrons who went to the establishment. However, with the most recent DPHS guidance, where we were having the establishments have a sign-in sheet for their clients or their patrons, and that was added in just to help again with our contact tracing, where we've asked these establishments to hold on to the sign-in sheet for 30 days, and then God forbid there is a case in that establishment, this would help our team in already having a list of individuals based on the area that they were seated at or the station that they were at, and who was the employee that assisted them. And so that guidance, by including that requirement, will help us to worry about that second situation.
And can I ask, when you say it will list community contact, will that be broken down into any additional categories? And I guess your debate that what Annette said about particular establishments, that would apply to community contacts.
Yes, and we already have a draft with some data, but I don't like the looks of it. It's, again, a work in progress. We want to streamline it so it's a simple and readable graph for the public, as well as over time looking at household or travel contacts or workplace contacts. So again, it's a work in progress. As soon as we migrate the data, we already have a draft template, so we're working on it.
All right, I had intended at this point to put up a copy of the current situation report that's on your website so that my colleagues could view it, and that you could discuss it with us as to, why there aren't additional details there. But okay, so you're saying about in 2 weeks, we'll see a different type of report and with a little bit more detail?
No, in 2 weeks, we will have migrated the data into the system to better and more accurately depict what we want and to manage the data better. I don't think it's going to happen for another month till we get a draft, and it might take longer than that, because the daily sit rep currently takes 6 to 8 hours to produce, and we're trying to streamline that so it's a little simpler. We're also streamlining the dashboard. So once those kinds of more simple, direct data that's needed for just the daily sit rep is set up, then we're going to go into more detail with a weekly surveillance report.
All right. Okay. So for the current, it's going to be a month. Then for the current situation report, could you tell us under community contact and workplace workplace is co-workers, I would assume, but community contact, this is almost every other establishment on Guam. You've got household, healthcare, community, or workplace contact. So under community, right now, the public's unable to determine what type of community contact you're talking about here. And
correct. And we will try and put more detail into the weekly report, the type of community contact, the establishments. And again, it changes. So what happened in August with churches and funerals is already past tense. We have other types of community contact, for example, congregate setting.
Right, which is why we keep asking this question about, what information can be disclosed, because we it's we're guessing, or we're being told that the decisions that are being made as to closures of businesses are based on these data, this information from public health. And it's very vague at this point, the way it's being reported to us. And so we would like to follow along with the decision making, because otherwise it's unclear to us why all businesses are closed versus, construction. We're completely unable to tell from this, for example, that like you described, that there are funeral clusters or any other type of cluster, church clusters. They're talking about church clusters today, but it's not clear from this. And is there any way to at least get that part of the data up, as soon as possible? The community, break down the community contact?
Not at this time. There's only 2 of us, and we just got someone on board assisting. And like I said, we're migrating all the data into the data management system, and it's just going to take more time.
All right. Well, when it's reported to the Physicians Advisory Group or any other groups, is it reported in another way besides these categories, community contact? Are they given more detailed information?
I believe we don't report directly any numbers to the sit rep. They get it, I assume, off the dashboard and the daily sit rep. But Dr. Felix Cabrera of the Physicians Advisory Group is compiling his own data, and they have a whole set of indicators that they're using. I don't know that the Physicians Advisory Group is taking our sit rep and making decisions based on that. It's based on other criteria developed within the Physicians Advisory Group and Dr. Cabrera.
Well,
so
are they obtaining cluster information from public health?
Not detailed cluster information. They're basing it on hospitalizations and their criteria for PCOR 1 and PCOR 2, and then I believe they come to some kind of consensus based on generally what's going on with the numbers, the surge in August and September, and then of course what's going on at the hospital and how many deaths there are. They're using the total numbers. I don't know that they're making any decisions about businesses opening or closing based on any cluster information.
All right. Well, we've heard some of their members discuss in the media known clusters. And so I guess that's where the confusion is coming from now, because we can't follow where they're getting those known clusters. And you're saying you're not reporting the known clusters to them either. That's
This is the media. The media has been doing this from the beginning, reporting deaths publicly, reporting clusters publicly. That's not official public health.
No, it's not. Getting it from physicians in the Physicians Advisory Group. And we were told at the last hearing that public health is attending those meetings and is advising the Physicians Advisory Group. So, okay, but I've heard your answers, so we'll deal with that now.
Can I say one more thing, please?
Sure, yes.
I am the only, except for the 2 doctors from GMH, I am the only person now from public health on the Physicians Advisory Group. That group is comprised mainly of private sector physicians and clinics. And the group basically comes to a consensus about whatever they decide, and then they provide that information to the governor. So it's not like they're asking detailed information from me, twice a week. It's a group effort and discussion.
All right. So does public health, just to clarify then, does public health report the detailed cluster information to the Physicians Advisory Group on a regular basis?
No.
Okay. But you have that available within your own department?
We do.
All right. Okay, thanks. When we looked at your situation report, maybe, Josh, if you could put that up right now, the staff. I want to show the senators the situation report. This is on their website, Public Health's website. So we're just going to talk about the data that they do have there real quickly, and it actually looks like this for September 30th, 1,564 cases out of the 2,488 positive cases on Guam have an EPI link. That means you were able to trace where the individual may have contracted the virus. This is about 63% of all cases. And so it also looks like 466 positive cases have been reported by the DoD. Do any of these cases have an EPI link, or are they included in the 1,564 cases identified to have an EPI link?
It depends. We do include our running totals from the Department of Defense. They, however, do their own contact tracing investigation. And we also do not have complete information on where people, what their EPI link is. Some of them are just, we do not know.
Right. Well, but these ones in this screen, can you see the screen?
Yes.
Those are known, is that correct? I mean, they're known at least to be from these contacts.
Yes.
Okay. So so you've got about 145, which is only about 6% of the 2,488 positive cases. And 118 were identified in quarantine, which is 5%. Well, no, those are the known. And it looks like 87% of all cases. Am I reading that right? Do you have our tracing is looking good if we know 87% of how 87% of the cases were contracted?
I don't think it's 87%.
Okay. I'm not a numbers person. How would you read this?
Hang on.
Okay.
It's 63%.
Okay. Well, all right. Well, if I guess, yeah. I started with 63, but then I added in the DoD and others. But okay, so those are not known. 63%. And
no, you can't mix those numbers up there. Those are actually separate tables within a table. They may not overlap.
All right. That's why I'm asking you. Yeah, were the DoD numbers included in here or not? Okay.
Off the top of my head, I don't know.
All right. All right. And I've already asked you about the breakdown of the community contract because that's the bulk. So the bulk is in the household and the community contract. And all right, so that's good. That's all I need with these slides. Just wanted to show the information that's available and ask you those questions. Okay, please.
Proceed.
Yes.
All right. Number 8, during the September 10th oversight hearing, the department said it would provide a copy of the AG's opinion to the committee. Please provide a copy of the opinion prior to October 1st hearing.
So, Chairwoman Terlaje, with regard to the opinion, it's actually guidance that we received, just to clarify. And the guidance we also further received was that if we were to release it, then we would no longer be able to maintain client attorney privilege. And still having a work in progress in terms of identifying establishments by name or by clusters or by categories, we felt at this time it would not be advantageous to release the guidance that we receive at the Attorney General until we can come up with our own in-house criteria that will then lay out when exactly do we identify a name of an establishment, or do we, only when it's difficult, to do the contact tracing. As Annette had mentioned earlier, the new guidance we have now requires establishments to maintain a list of visitors or guests or attendees or people who visit their establishments, and that list is maintained for 30 days. We believe that tool in terms of contact and case investigation will be helpful, but it is guidance. I had asked if I were to release it, and they just said, once you release it, you no longer have the client attorney privilege provision or perhaps option. And so we wanted to come up with a criteria in working with Dr. Ann. Of course, as you heard, it's a work in progress. We are looking at identifying perhaps types of establishments be in the construction trade or the restaurant establishment. As she shared also earlier, there was a funeral cluster. And so that's where we're at on that. But again, just to provide clarity this afternoon, I'm sorry, it would be a guidance as opposed to an opinion, Senator, Chairperson.
All right, then let me ask you, Director, is it your understanding that the Department of Public Health is prohibited from releasing certain types of information, and what information is that?
In terms of, other than health information, Senator, which I don't believe is what you're asking, in terms of this, it's just to release the guidance, just what the guidance contains, and that's all. In terms of what we can, at the discretion, as we shared, identify, but it would have to be related to involving contact tracing. You know, you can't just release names out just for the sake of doing that. You would need a work purpose and function and need to do that. So as Annette indicated earlier, if the establishment is cooperative, the question is naming the establishment critical to the investigation? Our thought on that at this point is more about the establishment being cooperative. And if the establishment is not cooperative, then the department has the option to name that establishment in the interest of the public health for case investigation and contact tracing, Chairwoman.
All right.
I really struggle with that for some reason.
All right, thank you. Please proceed.
Thank you, Chairwoman.
Okay, thank you. What type of detailed information regarding positive cases is disclosed to the Physicians Advisory Group and Governor, which is used to make the determinations on what types of businesses or activities are allowed to open, and why is this information not provided to the public? For example, how many positive cases are related to funerals, restaurants, bars, retail stores, churches, quarantine, health facilities, and personal services, etc.? How many cases can be traced back to another case, and how many are still unknown?
So we're calling Dr. Ann.
Dr. Ann?
Yes, I believe I already said that we would try to include the types of establishments in the weekly surveillance report, and that's a work in progress.
Yes.
And we hope, and again, we have some of the data that we've compiled, and it needs to be cleaned up and fixed up, and we're still waiting again on 2 weeks of data being migrated. So give us just some more time and we'll have something soon.
All right. Okay, next question.
Okay, moving along. Question number 10. What is the status of the supplemental request to the governor for the $3.09 million in coronavirus relief funds? Has it been received and or encumbered yet by the department?
To that question, Chairwoman, no, the funds have not been encumbered. I want to first of all thank you for your advocacy in that area. In working with you and the governor, we do have the memo indicating that we will receive those funds. I am in communications with EBMR and waiting for them to identify the account number. And I'm asking, of course, a follow-up after, shortly after this meeting again. But Chairwoman, we have not encumbered any of the funds at this time specific to the $3+ million that was communicated by the former director, and of course through your follow-up and the governor's response to you as well as to me with regards to the coronavirus funding for support to public health and social services, which is comprised of personnel and supplies. And so we have not encumbered any funds at this time, and I'm waiting on the account number, which may or may not already be sent to me as we're doing the oversight. I will have to get back to you on the account number, or at least that we have received the account number. And from there, the Dr. Kaneshiro, personnel staff will need to work on processing either recruitment. Actually, it's very far reaching. It's all the divisions, not just Dr. Kaneshiro. Funding is also for environmental health, senior citizens, and public welfare. And then I believe I actually have it in front of me, Senator, because but to the question, the immediate question, funds have not been encumbered.
All right.
Please
proceed.
Oh, okay. Thank you, Chairwoman.
Question number 11, provide an update on how much of the federal funding for case investigations and contact tracing has been utilized or encumbered. Please provide details and how long this funding will be available for this purpose. What amount of these dollars remain available?
Okay, what's been provided for contact tracing in the case of investigation were provided through like 4 different awards, and they total $6,289,236. Of this amount, 12% has either been encumbered or expended, and that amount is $370.85, which leaves an available balance of $5,480,865.15. Now, in terms of like the period of time that's been provided for us is through May of 2022, and that can go into the details of the amounts and what it covers.
I guess General Net, if you could just tell us if you've already described the use of these funds or not, or if this is in addition to what you've already described. Yeah.
What I had mentioned earlier, Madam Chair, in regards to the 14 personnel over the 2 grants, the enhanced detection and the CARES Act. Yes, ma'am.
Okay, great. So it's planned to all be used. Is that correct?
Oh, yes,
Yes, ma'am.
absolutely.
All right. Thank you. Okay, please proceed.
Okay, next question. How many additional Division of Environmental Health public health officers have been hired during the public health emergency to assist the monitoring for compliance of not only sanitary regulations, but social distancing mandates? Tom?
Yes, thank you. Madam Chair, since the start of the emergency, the Division of Environmental Health has not recruited any new environmental public health officers to conduct any sanitation inspections and COVID enforcement. However, just last week, we did have conduct interviews of applicants to fill the 4 vacant funded environmental health positions. So we hope to recruit additional staff going into this coming fiscal year.
Thank you.
Thank you.
Next question. What is the status of the new Bureau of Emerging Infectious Diseases? What is the timeline to get the new Bureau fully staffed and contact tracers, nurses, and microbiologists on board?
With regards to the question here before us, there was over perhaps a month of discussion, deliberation between myself, Chief Public Health Officer, Annette, our BCDC Administrator, our deputies, some conversation with our CDC advisor, Dr. Hancock, conversations with Chima and Balkans. So rather ironic, and it seems, well, what a coincidence, but not planned. We were working on this as late as into the evening and early today. We have since sent out the first memorandum for fiscal year 2021, establishing the Bureau of Emerging Infectious Diseases. But in addition to that, and that is already with a few staff that the ELC, as well as the CDC Foundation funds, have already put warm bodies into. Also, in addition to that, Mr. Mbakwe Chima is going to be the interim program manager to lead the Bureau in its development on onboarding of staff, also in defining further its functions and responsibilities. In addition to that, I may have shared with the body the intent to build the capacity of our local lab. So although BEID is the Bureau of Emerging Infectious Diseases, very closely related to that is the need to build our capacity for our local lab. And so having said that, the Guam Public Health Lab has been realigned. It used to be with BCDC, it is now reporting directly to the Chief Public Health Officer. And although it seems it's just a shift of who has oversight, it's more significant in the sense that we're developing a team, chairwoman and members of the legislative body. This team will be designed and be working towards building Guam's Public Health Lab. And so it'll be looking at the funds that are out there available, working with CDC, working with our in-house partners and our funding streams that already exist, and those that we can tap on to build our lab. And that's another development that we're, in terms of capacity building. We already have Mrs. Anne-Marie Santos. She is a lab administrator. And so she's now been, we discussed this with her, and she is now going to be reporting directly to Dr. Kaneshiro, and her tasks, along with the members that will be identified, to include CDC engagement. And I also want to say that CDC at the national level, representatives I've been speaking with, are very interested in us moving forward with the Guam Public Health Lab. And they're in full support. I've made some asks already off them with regards to technical assistance, and so we're excited about that. But of course, that's months away, if not a year or so, to put all this in place. But that is the direction we're moving with the Division of Public Health. There'll be other realignments within that division and perhaps other division. But for back to the question of Bureau of Emerging Infectious Diseases chairwoman, that bureau has been stood up as of this very day, and including the lab has been realigned, as I noted earlier.
To have you repeat anything, but that last part I couldn't hear because of the siren. I know you.
Yeah.
Lab, which
sorry, Chairwoman.
Isn't that correct, Director? The lab is separate from the bureau.
Correct, but it's another realignment that I just wanted to share with you this afternoon, Chairwoman. Yeah.
All right.
We're looking at building our capacity. Sorry.
All right. So thank you for the update on the lab also. So the bureau, I know that grant extends out at least a year, maybe two. Is that right, or longer?
Yeah. And that's,
so when do you expect that?
Yes. We have 24 months as well as 34 months for the enhancing detection, which is the 5.6 million. We have that until 2022, ma'am.
All right, thank you.
Okay.
Okay, please proceed.
Okay, moving along. Provide an update on the number of cases in Superior Court regarding DPHSSs and individuals in quarantine. There have been a number of changes to the guidance regarding quarantine of individuals entering Guam. According to the court cases, DPHSS did not follow the process outlined in the law. Are you now following the law? Please provide an update on how the protocols may have changed as a result of recent court rulings. How much are you spending on lawyers' fees for these cases?
Chairwoman, with regards to that question, we have 14 individual case numbers that have been filed, starting with the more latest. Sorry, I don't know if you're able to hear me with the vehicle passing by, so I'm going to pause a little. Okay, so we have 14 cases that have gone through the system at this time. They're special proceedings, and with regard to the process that has now in place, every traveler with a team up at the airport are requested to consider to help us with the quarantine process in place and are asked to voluntarily quarantine. In addition, if they make a statement of any degree that they are not in agreement, then there would be the involuntary option or order, temporary order for quarantine issued along with Article 6 and its definitions. In addition, that also contains a provision that they do have the option for legal representation and no cost to them. That information is also provided to them. And at this point, with regards to lawyer fees, none have been determined at this time. There has been a statement by the judge who is hearing the cases that will come at a later time. So the protocol and the process of the airport has changed in that regard. In addition, you all probably know the quarantine process has also changed at the quarantine facility. On day 6, they would also be the option to test, and if they test negative, they will then have the option to transfer home to continue their quarantine. And the reason I say the option is, interestingly, we have had a small number of quarantine residents, travelers in our quarantine facility who, after being notified of being negative, requested to remain in the quarantine facility at Dusit Beach Resort, and perhaps even Dusit Tani. And so just to let everyone know, we did inform their attorney of this decision, and it's documented. And so The protocol at the airport has changed. It's voluntary. You make a statement that you're not willing to do that, then of course we will offer the temporary directive for quarantine is issued, the Article 6 and its definitions, and including as the notice that you of course have option for legal representation at that point at no cost to you. If it may be worth mentioning, Chairwoman, with Chima and the team that have been working this process, the process back in March up until the court proceedings were not changed. With the result of the court proceedings, the changes have then been made in response to the court orders to ensure compliance and adherence to the court orders that are being issued. But I just want to make that note because I had thought also perhaps that there was a significant change or any minor change in the process starting March. And there was none, according to the processors and the folks that have been here since March, Chima and the other Chima and Walk and all the other team members who have been very engaged with the process since March. And so I wanted to offer that to you this afternoon, Chairman and members of the Guam Legislature.
All right, just to clarify, is there anyone at the airport who is discussing the voluntary versus involuntary with the people, or are they just handing them the flyers or the papers?
Oh no, they're actually being told they have the option. You have the option for voluntary or involuntary. This is what happens if it's voluntary. If it's involuntary, we'll give you a temporary directive for quarantine. Here's our, which also requires us to issue Article 6 and its definitions. I'm sorry, you have a question.
Who's doing that at the airport? Who is informing the passengers at the airport of that?
Well, we have a team. We have a team out there, Chairwoman. We have a team of some of the individuals have been deputized, and they were deputized to facilitate that. Then we have some staff from public health who have since been trained by those that were deputized to process the inbound travelers. So we have a team up there that also works with Chima. And Chima goes up there and also talks with them. We have a lead, Rebecca Respicio, who's also very engaged with the process, and others that are deputized.
All right, yes, so I think we saw them. A lot of the senators went on a tour of the airport several months ago where we were shown how the public health, and we even saw, Director Respicio there. But so my question, are these the same people that are advising now the passengers? And yes, same type of team there. Okay. So they get written and get verbal advice as to their rights.
I wanted to hear your question. Sorry, Senator.
Sorry, I just wanted to confirm whether they're getting it in writing and verbally as well. And
well, they get it verbally. We have a script, and they use that script and they read off the script, and then there's actual paperwork that is issued to them depending on which option they proceed with.
All right, can you just speak up? Also, one of my colleagues is asking if you could speak a little louder. And the 6 days testing and release, is that a public health decision? Do you agree with that policy? Is that safe for Guam?
Well, it is a policy that we were part of the discussion, and we were in agreement with the test. We also recognize that there's some value in home quarantine, provided we had a system, and we were really banking on SARA alert to make this all work together. And now that we have a system that, is it Chima 100,000?
Yeah, capacity.
A system that can hold 100,000 monitorees. And so we wanted to be sure we had some kind of application that could help the manpower, the person manpower, and then the automated version, or not so much an application, but a tool that helps us with the monitoring aspect that needs to happen. And so the capacity of 100,000 and the ability to test, offer that with a negative, then it would seem that it would be a suitable approach that we would then be able to continue home quarantine. And I think it helps at many different levels also, Chairwoman, in terms of the returning residents.
All right, but the 6 days testing, after the 6 days test, they go home. Are they still under quarantine up to the 14 days?
Yes, they are. They continue on the home quarantine.
So are those people under quarantine and not under isolation also supposed to sign up under the SARA alert? I mean, the SARA, that
Yes, ma'am. So we altogether have two systems. So the first SORA alert is for inbound travelers. It has a 2 weeks turnaround for monitoring. So if you enroll in that system, after 2 weeks, it actually clears out the data of the individual if you don't turn positive. But if the individual ends up turning positive, they are transferred to the Guam response, which is also one of the technologies we're using in-house to monitor active cases, which is part of the NBS system that we're using. So the SORA alert is basically for inbound passengers coming into the island to make sure that we monitor them for 14 days. And then we're banking on that also. When we open up the island, we're going to use it for inbound tourists as a means of monitoring them while they're on island.
Is that functioning right now?
We just launched today.
Today?
Yes, this morning by 8 o'clock.
Okay, all right. I wonder why. Okay, and so they're both, say the names again, Sarah, the two, yeah.
One is SORA Alert by Mitra, and then the other one is Guam Response by Inductive Health. Inductive Health is actually the system we're using for the NBS. We actually have a demo site if you want to register to see how it works. We can get your information and then register you on the demo site for SORA Alert so that you see how the system works.
Well, we've heard about this as the one of the tools that we're going to use to open up to tourists. So yeah, we're glad to hear that it's launched today.
Yes.
All right, but you're going to be using that now for all travelers coming in to monitor them up to the 14 days after they're released from the hotels.
Yes, ma'am. So we'll gradually start registering the individuals in the QFAC as they go out and the ones from the airport.
All right, great. Okay, we're almost done, colleagues. Please proceed. Director.
Okay, question number 15. Last week, some restrictions were lifted and certain businesses and activities were allowed to open with specific guidance from the Department of Public Health and Social Services. Do you agree that the businesses and activities were opened up recently are low-risk establishments? Did you recommend that these businesses or activities be allowed to open up to the governor or the physician's advisory group? Are there other low-risk establishment or activities, retail businesses, and personal care businesses that can also open up with strict guidelines?
You want to take it? Sorry, you want to respond? You want to respond?
More than happy to.
Okay.
Yeah. So, Madam Chairperson, Department of Public Health and partnership, of course, with the governor as well as the Physicians Advisory Group is about transparency, of course, communication. And so on a daily basis, we have a call-in with the governor in which several members of the PAG are on board with that. And it gives us an opportunity to really look at the data. And based on the data, the numbers of death, numbers of people tested, the numbers that test positive, to really get a feel as to what the movement or activity is here on island. And based on that, we can go ahead and determine if there are low, medium, or higher risk activities that people can do. For example, today we talked about certain sporting activities that perhaps can open up with minimum amount of contact, certain activities such as yoga that can be done outside. I mean, we talk about actually quite a number of things before they are released out to the community. So those are just examples, but yes, definitely that transparency between the team makes a very big difference, because in essence, it's all of us coming together to support and enforce these decisions.
All right, the question is more towards what was your recommendation? Yeah, so, okay, so you're sharing these recommendations. Are they consistent? Is the current executive order consistent with your recommendation?
Yes, I would say they are.
we'll move on. Next question.
So technically that concludes, that's the last question, question number 15. If there's anything that you'd like to revisit or any questions you have, I'm sure the floor is open.
Oh, one more question is, those who are released from the mandatory quarantine, they're told to go home and quarantine, but I received calls at my office telling me that they're also told that if they need to go out and get groceries, they can do that, or they can go out and exercise. Is that correct?
Yes, ma'am. Yeah, because they're still in mandatory 14 days quarantine. And because we are monitoring them, we want to make sure that we understand where they go to in case they turn positive, so that to help us in contact tracing.
But you're allowing them to go to the grocery stores and out to exercise while they're under quarantine?
So that's why I said they need to get permission, and I don't think anybody is allowing them at this point.
I received calls at my office that says they're being told that that's what they're being told. That when they go home to quarantine, they have to stay home unless they are going to the grocery store or out.
Yeah. So this might be the individuals on the restriction of movement.
All right. If you could please clarify, what the instructions are for people who are being released after the 6-day test.
So for individuals who are on restriction of movement, they're allowed to carry out certain activities under the restriction of movement, which is different from individuals who are close contacts to positive cases, who are not allowed any restriction of movement, but are asked to stay at home for the 14 days and are monitored twice a day. So with the individuals that are released from the quarantine site, you also know that they were actually tested for COVID and they were found to be negative. But we still want to monitor them within the remaining 7 to 8 days to make sure that when they develop symptoms, we're able to know where they went to and who they were in contact with. Because at that point, we're still monitoring them, but it's with restriction of movement.
And so they're going to grocery stores, and you're able to handle that if they turn positive after the 8th day?
Yeah, because so with restriction of movement, it's easier for us to identify where they went to. And the risk is less because already they've tested negative, and if for any reason they develop symptoms, we can quickly follow up. But it's different for close contact to positive cases that have a higher probability of turning positive.
All right, and then, okay, so we know that now. All right, I want to thank you. I have 3 more questions, if I could just ask, and these were posed. One is ongoing community COVID-19 positivities, 8 to 10%, according to JIC, the Information Center. This indicates ongoing community spread of infection with improved public health workflow, as you described today. Does public health now believe they can adequately trace, contact, and control the spread of infections more effectively moving forward?
Oh, that's the only question.
Annette, I guess I'll ask you that.
Yeah, Annette. Yes, or not?
Can you repeat the question? Is this the one from
Dr. Kim? That's correct, yes. It's pretty much your confidence moving forward now with what you've described and with the infection rate that we have, the positivity rate that we have.
Yes, ma'am. Thank you, Dr. Kimoto, for the question. Yes, we are still confident in our ability, especially with the recent adjustments that we've made with our isolation and quarantine team. Also, we've seen a rise in the recent cases due to household contacts turning positive. So these people have already been identified, and as Chima has mentioned before, mitigation efforts were already put in place. So unfortunately, they've gone from household contacts or work contacts to now cases. And so the majority of work has already been done. And so even though we are still seeing double digits, again, due to the high number of contacts identified and tested, that's where we're seeing a lot of new positive cases.
All right. And what will public health be using to advise the governor when to open schools and businesses what are the metrics when you say we recommend it or it's not risk?
I know Dr. Ann can probably speak a little bit more than me, but it's a combination with what, yes, the PAG has with the P core condition. They look at the hospitalization rate, the fatality, the positivity rate, and then we look at the additional information that we have about if there's any recent clusters, and that information is discussed with the PAG, and recommendations are provided to the governor on how to gradually reopen.
Are you going to respond?
Yeah, respond.
You gotta start.
Is there a certain number of cases in a certain cluster where you would say we need to close those businesses? I mean, have you got that type of guidelines down? Or where we would need to close this entire industry, or we would need to, or we don't need to, because you've got the cooperation of the businesses and can trace everybody within the days?
Well, we have our internal process, ma'am, where we are working with the Division of Environmental Health. That should an establishment have a cluster, which we define as 5 cases within a 2-week period, that we would then notify through my chief, who notifies the environmental ops chief in regards to that situation, so that they can just do a site visit, an assessment, and just to see if that establishment, and I know Mr. Tom Nadeau can speak more on his division side, but we have that collaboration communication across our divisions for that, ma'am.
All right, and again, this is from Dr. Akimoto, and he's here. Doc, I'll read this question, but I'll give you the floor also. Once Guam Public Health has hired its goal staff, will the governor be able to safely reopen Guam to tourists and bypass the 14-day quarantine if they stay less than 7 days as previously approved by the Physicians Advisory Group? I guess I'm going to ask the director that.
With regards to Dr. Akimoto's question with less than 7 days, I'm thinking it's a private protocol. So if the question is, if this, I'm trying to read this question, does exist, what is it, personnel composition and workload capacity, Doc?
No, the question about if public health has hired its goal staff, right? The one that we've described today, will we be able to open to tourists and bypass the 14-day quarantine because of our tracing capabilities if they stay less than 7 days as previously approved by the Physicians Advisory Group? This is in recognition of the SARA alert app being implemented today.
Sure. Chima would like to add on before I go ahead.
Okay, Madam Senator, I think opening the island is based on a lot of different factors, just not public health. Because first of all, we're going to look at our healthcare structure on the island. What level of infection control, what level of practices do they have before we open? For the response, public health is leading the response now as a sole entity, and everyone is reporting to us. Oh, sorry, we're leading the response. But as we gradually open the island, the first port of call for anyone who is sick or is symptomatic will be the clinics. So we also need to know how prepared the clinics are for us to open up. Because as we open up, public health, like I've always said, is the last to know. Because public health relies on reports from the clinics and the hospitals. So if the clinics are prepared enough to support the opening, then it's also for us on the back end to say we're prepared. Because right now, if we have adequate staffing for reopening, and we don't have that linkage, or we don't have that, if we don't have reports coming from the clinics, which is already challenging, and also the hospitals, then public health will not be able to identify those people that have tested positive, those people that need to be traced. So that is also part of what we need to look at before we talk about opening. Because right now, for us to open, the clinics will also have to be doing the testing for COVID positive. They're also going to see patients who come in with flu-like symptoms that they will test and they have COVID. We need to make sure that we have a system in place for them to notify public health on time, for us to actually activate all the processes we have in place to support to make sure that we cut off the spread of infection on the island. So it's a two-way approach: public health response, and also the public. Do we have enough education out there in public for people to know if they are sick, to go visit the hospital? If they have symptoms, do they go to work or do they stay back at work? So it's a lot that we need to put into perspective before saying that we're going to open. So on our own side as public health, we're ready if we have all the support, all the staffing and technology we actually have now, but it's also relying on our partners to also make sure that they will report to public health if there is anything happening in the community.
All right, maybe if you could, Director, just submit an answer to that in writing that it would look like a plan as to if these factors are in place, these conditions or these actions these businesses could open. I don't know if there's something like that. I know everybody wants to see a plan. So anything that you've got that resembles that. I appreciate your answer, Chima, and all of you. And I want to thank you all for answering my long list of questions, preparing this in advance, and being very succinct with your answers. I very much appreciate all your cooperation and assistance with this. And I'm very glad to hear the progress that's been made by Public Health. So thank you very much. I'd like to now open it up to my colleagues who've been waiting quite a while also. So Senator Vice Chair Sabina Perez, please.
Thank you, Madam Chair. And this has been a very good oversight in bringing information to the public. And thank you to Department of Public Health. Yes, I see there's a lot of improvements, leaps and bounds from the first time we had oversights, and you've responded in kind to the surge. I think ultimately it's about how do we control community spread, because that's the largest contributing portion to COVID infections here on island. And so what I'm hearing is that we still have improvements to make, and just my concern as we're opening up businesses, how do we prevent this third surge, right? So what are the factors, or what are the things that we need to take care of before we open up more, to prevent a third surge from happening. So I know some things have come out in this discussion, but maybe if you can highlight some of the things, areas of improvement that you think that can be taken.
If I may, Senator?
Yes, thank you.
Until there is a medication or vaccine, we anticipate more surges. So unfortunately, it does take a community effort. Again, public health cannot do this alone. Our private healthcare partners cannot do this alone. It really is individual responsibility. And I know Chima has spoken to this in the past oversight hearing. It's a behavioral change. Again, we're still hearing people going to work who are sick, going to visit family and friends, having functions while they're sick, not wearing masks, not practicing social distancing. So until there is a medicine to prevent it or a vaccine to prevent it, it's those social distancing measures, wearing your mask, covering your cough, staying home when you're sick. And I know that is a challenge, especially for our brothers and sisters in the communities that they're the only sole source provider and they need to go to work. And so it's something, again, on the employer side where we ask, have some flexibility, allow them to stay home if they're sick. But again, it is individual responsibility as well as a government and community responsibility, and again, a partnership and collaboration to help prevent the spread and another surge. Thank you.
Thank you, Annette. And having said that, as far as this COVID alert, this is questions for Janella. So what do you think are the barriers to increasing the reach for this COVID alert? And I'm also thinking, I almost feel like it should be required of all the government agency heads, but I know what are the issues of requiring COVID alert to be, downloaded with our agencies?
Thank you, Senator. So one of the biggest concerns we've had about the Guam COVID Alert app has been privacy. I think that's it's been an ongoing issue from the public, and it's one of the issues we've been trying our best to address. We've had a team of experts from Vince Munoz, who's one of the early developers who's participated in the actual development of the app. as well as Shante Benitez. We put him on. We've also had Dr. Ramesh when we had the initial launch of the Guam COVID Alert app to try to address these concerns. We've put together some materials like FAQs, fact sheets, some graphics to try to address these concerns as well. And it's ongoing. We're still trying to address it as we speak. So that's one of the main barriers. The other one as well is just trying to reach pockets in Guam as far as areas that may not be reachable. So that's another issue that we're also trying to address. As far as requiring, I'm sorry, go ahead.
Yeah, could you just get to the part of the question regarding whether it could be mandated, especially in government?
I do think it could be mandated as far as government, and that's part of the challenge that we put out. I know that we did ask the chief or the acting chief of staff to put out a circular, and I think that's part of the challenge that we're putting out is asking GovGuam employees within the executive branch. I don't think there's anything that's stopping the legislative branch from requiring or even asking its employees to download the app onto their phones. We are encouraging businesses to do the same with their employees. And it was also discussed that it's something that we ask of incoming travelers. So we put it in our guidance memo when we released revision 10 for incoming travelers. But as far as a mandate, for example, for travelers going to home quarantine, I think perhaps it's something we might have to visit with our legal team. I'm not sure if that's something that we would have to, if it's something that we have to make a requirement, what the parameters are, because there may be some challenges as well for that. For example, your phone may not be the latest iOS device or something to that effect. So we did discuss it when we did revision 10, the latest guidance memo for the travel quarantine. But we decided to encourage users or encourage travelers as opposed to requiring it, just because we weren't sure about the parameters of the cell phones of each individual traveler at the time.
Just one more question. In regards to contact tracing, what are the initiatives to expand that to beyond what the agencies that currently have contact tracers? So I'm thinking, other agencies like DRT. Has there been any success in getting other agencies to have on-site contact tracers?
Well, we're starting, ma'am, in regards to the UOG pilot project, which does have a mix there. Serve Guam has a representative that attended the class, and they administer the AmeriCorps, and that was actually one of the partners we were looking at the beginning to expand for contact tracing. We have Catholic schools on board, one representative, and then DOE, as well as 3 UOG. There are other participants. There was a total of about 94 who 85 to 94 that took the UOG UC San Francisco contact tracing program. And so once we get this pilot project in place, and then we can look at expanding to other government agencies. We've also had a couple of private establishment entities who inquired. We refer them to the online course. And so similar to what is happening at Port Authority of Guam and Guam Power Authority, where they identified individuals, they've taken that course. They communicate and coordinate with my team in regards to the full investigation for the contacts and interview, as well as scheduling for the testing. And so we are slowly expanding that out. We are, as we get more staff on board as well, it'll allow my team to have some flexibility to have some of the seasoned investigators or contact tracers train individuals. And I failed to mention, or I apologize, but DYA has also been helping us. They continue to help us. We've already had 5 individuals trained to do contact tracing, and already we have 2 that are now being trained up to do case investigation. And so again, we're building that capacity slowly but surely. But as we onboard more staff, then we can definitely take advantage of all these individuals who've taken the online course or as Dr. Kanisha mentioned, the 38 we have in-house, or the other individuals who took the UOG, UC San Francisco, and continue to build and expand out on that capacity.
Great, thank you, Annette. I think it's so essential that our government provides the role model for the rest of the community. So I do appreciate Department of Public Health, 38 individuals at least within their own agency for contact tracers. And I look forward to more of the agencies providing this role model for our community. So yeah, thank you so much for the hard work that you guys are doing. Thank you, Madam Chair, for this oversight and great questions and briefing the public on a very important issue. Duzmasi.
Dr. Akimoto is also on with us, and I would like to invite him. And I know Public Health, we've asked you to take note of his questions on the chat. And if you could just take note of those and please provide answers when you can. But Dr. Akimoto, you're welcome if you would like to say something.
We can copy the message so that we can respond to it. Dr. Akimoto, it's a long one. So
no, I'll defer, Senator. I think everybody's doing a great job, and we just appreciate people putting their work in. I put my stuff down verbally, but thank you very much.
I appreciate those very good points, and I hope Public Health will address these and if they send it to me, share. All right, we'll move on now to Senator Terlaje, Minority Leader.
Thank you, Madam Chair, for the opportunity, and good afternoon, Public Health. Thank you again for taking the time out and providing all this information. I think it is very helpful when we're doing these roundtables or oversight hearings that we provide you the opportunity with these questions first. That way you can get all your data and research together. Greatly appreciate that hard work you put into this. And I'm pretty sure, considering where we're at, there'll probably be another oversight later on down the road, because it looks like there's a lot of things that still need to get upgraded and put into place. I just have a few questions. Madam Chair was excellent on the questions that she brought up. But when the answers were given, I just need a couple clarifications, especially those who are coming into Guam. If I'm not mistaken, can you explain the difference between individuals coming into Guam who are working for, their civil service individuals working for DOD, are coming into Guam for the contract on the military buildup? They're not necessarily a member of the military, but as a civilian for the government. And then versus what happens when we have returning residents or people coming to visit family on Guam. And what is the separation? Can you kind of explain again? I guess, Chuma, they're probably going to ask you to answer this question. So,
Chuma, I'm going to ask Tom.
Yeah, when you answer it, if you can explain again the 6 days. I know that the military has their own, but that's their members. But what about civilians coming in to work as a contractor is one. Number two, when you say that now in place, you're starting the 6 days in quarantine. Can you start from the time you explain this, whether it's involuntary or voluntary? And I really truly believe not only verbally that you're reading a script, but things should be done in writing so they can just take their time. It's very stressful, coming in and having to deal with all this, but giving them that. If they are involuntary, saying, I don't want to be quarantined, what law requires them to then go directly straight to, you say, I'm okay, you're involuntary, but you still have to go into quarantine. So can you kind of explain that again, please? Sorry to have you repeat it, but just want to be clear.
Right. Mm-hmm. Okay. So, ma'am, I will start by explaining the DOD process. So for the DOD, we actually met and agreed with the DOD that for any contractor that is working on any of the DOD contracts, the DOD would take over the quarantine for those individuals. So they have their own set of quarantine rules that they went through with the Department of Public Health, and we approved their quarantine protocols. And what it means is that before the individual comes into the island, DOD will write a letter to the Director of Public Health explaining who the individual is and what makes the individual a critical service worker. and then they also put a ROM plan, which is a restriction of movement plan. So what that does is that the director will review it and approve it. The list is given to the airport, the public health staff and airport staff. So when these individuals arrive Guam, they are handed over to the DOD personnel that actually takes them to do the DOD ROM. And the DOD ROM is for same 14 days in quarantine, but with restriction of movement from their home or their hotel to their work site and back. So this is the DOD process. But for inbound passengers coming into the island, what we normally do is we accept them at the airport and offer them the voluntary quarantine form. When we do that and they refuse to take the quarantine forms, we issue them the involuntary declaration, and then they're handed over the Article 6 for them to read and understand why they are being involuntarily quarantined. And then they're also told that they will have access to a lawyer to take public health to court. So that is the difference between the inbound passengers and DOD.
So Chuma, when that individual passenger comes in and is not wanting voluntarily quarantine, involuntary, you give them the Article 6 of Chapter 19 and give it to them, and then you still bus them to go to the hotel regardless, right? And at that time, you're also provided to let them know that they can have an attorney if they so choose.
Yes, ma'am.
But they still must get onto the bus and go directly to the hotel, correct?
Yes, ma'am.
Okay, just wanted to, because there was a misunderstanding about that if you don't sign that voluntary and it's involuntary, you don't have to go there. You can go directly home and do your quarantine at home, but that's not the case. Okay.
Yes, ma'am.
And as far as a DOD, I read a case, Lang versus Department of Public Health and Social Services, when a DOD individual who came in to work for the military did not want to stay there because the individual had to pay for his own hotel, his own quarantine, and his own food. And he tried to get onto the government of Guam's quarantine location from public health, but I guess it and it said that public health said they have no problem with it, and DOD said they had no problem with it, but I guess there was some shuffling and confusion. So my question is, that will not happen. Once that individual is been identified as a DOD individual here to work, he cannot later on cross over and sit in a government of Guam quarantine. Is that correct?
Yes, ma'am.
Okay, that's good to hear. The other one is, when you talked about, the clinics and when we're going to be able to open up at the clinics have to all get into place to provide you the information. Well, I go to my doctor. I still up to this day go to my doctor. And I see other people going to their clinics to get seen. And I just don't understand the difference of what's happening today already. That's any different from what you're waiting for to happen, because we're doing that right now, going to these clinics. People were outside, keeping distance. And so what exactly are you waiting for if we're already doing that currently at these clinics?
Okay, so ma'am, in February, before we started the COVID-19 response, Public Health sent an infection control assessment to all the clinics on the island. And the intention was to find out what kind of infection control they had in place. Some of the clinics returned the forms and some didn't return the form. And the reason for that assessment is an ICAR assessment that is supposed to make sure that clinics have processes in place for infection control. First of all, for an airborne disease, it is also good to know if the clinic has an airborne infection, a negative pressure room or an identified room where they can keep people who have airborne diseases. We also looked at the engineering controls in the clinics to make sure that people are well separated. So these were some of the few. These were some of the things in the assessment that Public Health wanted to know and see how prepared the hospitals were in case they had situations where an infected person is in that clinic. And remember, like I said earlier on, if we open the island tomorrow, the first place anyone who is sick will go to is his primary physician. So we need to know if they have processes in place for referral. Like right now, we have some clinics on the island that are conducting the COVID-19 test. What structures do they have in place to notify Public Health if that individual turns positive? What kind of education do they have in place for that individual? I can give you a scenario. If someone walks into the clinic to get tested for COVID, does the nurse educate him about COVID? Do they tell him to go home and quarantine until he receives his test result? Do they tell him to wait for a phone call from Public Health to instruct them further if they have a positive result? So at the point of testing, we should have a level of education from these clinics that will notify the patient of the likely outcome of the case. This is one step. Two, for those in the clinic, for those in the hospital, when they get to the main hospital, if they are tested and they have to be discharged home because they are not going to stay overnight at the hospital, do they have a process in place to notify Public Health? So that notification, which under the law is supposed to be a reportable disease within 24 hours, we need to make sure that that structure is in place for the clinics to notify Public Health before we start. So like I always say, if we don't get to know about these cases, then it will become a problem for us to be able to control the cases, notwithstanding the number of staff we have. Two, if we're going to open up too, we're also going to look at all the establishments on the island, like Annette pointed out, which we're also working on, is to identify individuals in those establishments that will be trained to be able to support Public Health in their contact tracing. I am the TB manager and I have a staff of 9. I have only 3 contact investigators that investigate 450 cases in a year and conduct almost 5,000 clearances. These individuals are doing this because we have a structure in place that actually helps us work with this establishment. We work with the HR department of every establishment. These are the individuals who know where the staff work. They can tell us what shift they are. They can tell us when they are on vacation. So if we are going to open the island, we also need to have that structure in place, because even if Public Health has 500 people doing contact tracing, if we don't have this buy-in with these organizations, it's going to be impossible for us to conduct contact tracing, because information is needed from these establishments. Because at the point of testing, the individual close contacts, which are family members, are the easiest to reach. The community members are the most difficult to reach. And if we don't have this relationship like we have now with the TB program, which is an airborne disease, if we don't expand on that right now, we will not have the capacity to open the way we want to open. So this is in answering Dr. Akimoto's questions about a different Public Health entity that is doing the quarantine. I might need to correct that impression, because it's one unit. We run as a unit. So the new bureau that the department is opening up is to make sure that everything is under one unit, and it's going to be run the same way we run the TB program, which is having the contact investigator identify close contacts, follow them up to the point where they are successfully monitored, and if they have symptoms, they are tested, and if they are positive, they are correctly isolated, and their family members quarantined. Is an ongoing process that we have in Public Health, and we have we will have enough people in this bureau that will be trained to be able to do the actual case investigation and contact investigation. And then we can rely on the support that I explained to you to be able to manage what is going on the island. Thank you, ma'am.
Well, Chima, thank you so much for that lengthy explanation. And I could definitely hear, a lot of your hard work into this and frustration. I could definitely hear your frustration into it. But, I think public health also has the authority in Chapter 19. If you need to shut down an establishment because they're not following the rules and guidelines or providing the information you need, on a timely basis, considering that you have the authority to shut them down or close them, like you have been doing on some of these businesses if they're not complying. So I just still, I go to my clinic. I've gone twice now already. I'm seeing people come in there, and if they're not complying, then nothing stops anybody from walking into my clinic and getting tested and finding out they're COVID, because I know there's only one clinic, I think, that even has that airtight room that you were talking about earlier. But again, I greatly appreciate that explanation, and I'll be able, thank you, Madam Chair, be able to review the comments that were made again to really look into this more, because I guess what I'm looking for here, Madam Chair, and I'm hoping is that magic number, that we need to hit in order to open up our community. And Annette, thank you. Annette, you've been doing an amazing job, no doubt about it. You know your stuff. But I don't know, to me, and I've said this before, that the vaccine right now is called a mask. That's the only vaccine we have, a mask. And most countries are opening up their business and their economy and using that as their vaccine, because I don't know how long it will be, but I really appreciate all your work, and thank you again, Madam Chair, for all your hard work on this too. Thank you.
Thank you, Senator. Senator James Moylan, and then we will have to wrap up for the next public hearing by the legislature at 5 p.m. Thank you, Senator Moylan.
Thank you, Madam Chair. Just one question. I was able to have a brief conversation with Annette, but we'll continue on with Annette, please. It's just regarding the contact tracers. Now, we've been in PCOR 1 about seven weeks or so, and many of our government employees are at home and not able to telework, right? And I'm just wondering, of these possibly thousands of government employees who are still being paid, if we can have them also trained as contact tracers, and if we can possibly increase by 50 or 100 of our contact tracers, I'm supposing this will be helpful for Department of Public Health in improving our numbers of 63% of the EPI links to make it even higher. And if you can explain, Annette, how if this is possible or this will be recommended. And I know we had a brief conversation about, well, we need secure computers, we need telephones for them to use, and they have to be working out of a facility that just not be working out of home. And I think we can come to an answer on that, on how we can improve that. So Annette, please, can we get some more contact tracers from possibly these government of Guam workers that are at home and not able to telework or go to their office?
Thank you, Senator Moylan. Yes, and I appreciate the call earlier. Yes, we definitely would love to have more contact tracers throughout the government agencies. We've been fortunate that we've had DYA, but they've been physically located with us. And due to our situation last November, our department spread out over 4 to 5 different facilities on island. And so my team actually is spread out over 4 locations, from Del Rio Public Health, Grand Care, Castle Mall here in Manila, and then now in Terlaje building in Agana. And again, our contact tracers need to have a computer that's on the government network, a phone, so they can conduct interviews. One of our workarounds is to get additional cell phones so that people see a local phone number that's calling them. We do have people questioning, well, why is it a cell number, not a government landline? So we do have people call us back, and we will verify that, we are public health. because they're very concerned about confidentiality and their privacy. And so that actually leads to the issue of, oh, you have a lot of people that can telework at home. However, because the information we're dealing with is HIPAA covered, is a lot of personal health information. We are unable to utilize government employees who are at home because we don't know their security measures at home in regards to their network. Also, where's that computer and the phone in their household, and is there people passing by or in the same room? And so that would avoid the confidentiality and privacy that we need to maintain for our cases and our contacts. I know with leadership, we're looking at trying to obtain additional facilities and logistics. So again, that would be an opportunity as we bring on more staff through our grants and the CDC Foundation, or as you say, having other people who've been trained up and to utilize them, like through the UOG, UC San Francisco training, that we have adequate spacing for them and the desk, computer, and a phone to do the needed work. With the UOG pilot test, this will actually help kind of lead the way in that UOG is stepping up and providing us their own facility. The pilot team will be working out of UOG. They are providing the computers and the phones. And so that's something that we can definitely, are grateful for their support. In regards to having other contact tracers trained up in the agencies, similar to what we're doing with Port Authority, GPA, and GMH, and DOE, is have these individuals be our liaison or point of contacts at their respective agencies. It'll help take the load off our team of eliciting those contacts, getting were you at work or not, are you at the same time, same building or location, and so that will help ease the load on our team. But having that communication and collaboration, getting the necessary information, so then we can do the investigation and interview, and then schedule for the testing. So yes, sir, that definitely is a great opportunity that we look forward to expanding on.
Thank you, Annette. And I'll plan to have more conversation with the director, and possibly the governor can assist us with maybe additional CARES money to help provide these additional computers and telephones, so we can utilize several hundreds or more of these government employees that can assist us who are home and not able to telework and can come to a facility, maybe a government facility. We can have set up of a huge space for contact tracers, and we can help assist Department of Public Health and Social Services in making those contacts and getting our island back into shape so we can reopen. Thank you, Annette. Thank you, Madam Chair.
Thank you, sir. We appreciate that.
Thank you very much, Senator Moylan. And again, thank you to the senators who have attended this hearing and asked questions and helped me to inform the public. And I very much want to thank all of you, the directors and Augustine and the deputy directors and all of you at Public Health for, again, your leadership, your staff for providing updates on the contact tracing and investigations. This is the third oversight hearing since May 8th. In addition to numerous budget discussions we've also had before the legislature with Public Health. And we've seen progress since May, but as you know more than us, that this is an extremely fast moving virus. Things have changed very rapidly, but Public Health has been able to adapt. And I want to commend you for that you're adapting to different people, different orders, different, and the virus has changed, and CDC's guidelines have changed. Many things have changed on you, but you have been able to adapt and continue to keep moving. I really want to commend you for those efforts over the last 6 months or longer. And I'm glad to know that there's been great improvement in the contact, in the time that it takes to trace the positive cases or their contacts. And that Public Health has more than doubled staff for the tracing since May and still continues to bring more on. I'm committed to ensuring that you have the resources you need to be able to scale up the investigations and the contact tracing capabilities.
Tom did it already.
This is really opening up our businesses safely so that we can react quickly to any potential spread. I'm continuing to urge the department to provide data to the public to help them understand what information is driving the decisions going forward, so that the public has confidence going forward. We need to see more progress in this area, and we've got some estimates of time, so I'm glad for that. And we want to be sure that, want to be able to also ensure that the decisions are being made by the administration in consultation with the Physicians Advisory Group using the data on the clusters in real time. This is, I know it's challenging with your resources at this point, but please let us know how we can help. We really need this to be accomplished as soon as possible so that we can open up safely and instill confidence in the community and confidence that our businesses, when they open, can remain open. But again, thank you so much for your work. Please let us know how we can assist further. And I want to reassure the members of the public who might be listening that we will continue to hold oversight hearings, communications with the department, and that they've been very good about appearing on the radio and also being very public about what they are trying to do and accomplish and how they are doing that. And I want to commend them for that. And we will continue to do our part to also keep the public informed of the progress of public health so that they can be brought along in this process. All of our goals is the same. It's to keep our community safe, figure out a safe way to open our economy and systematically based on data, and so that they can remain open as much as possible. And so I know that you're all working together as a team, and we are all going to work together in government as a team and with our private sector, with our physicians and the public. So again, thank you to everyone, and I wish you continued luck going forward. We will try to do our part in regards to this, the COVID tracing app to help to ensure, but I look forward also to hearing from what you find out from your legal advisors as soon as possible, whether, how much mandatory, downloading of that app we can enforce. But otherwise, we will continue to urge that and continue to support you. So again, thank you very much. And this oversight hearing is concluded. It's 4:28 p.m.
Thank you.